Hello, hi. My name is Felice and I'm a pediatric neuroradiologist in London, the hospital called Great Ormond Street. First of all, I would like to thank the organizer for this kind invite. I really love to work with together with my colleagues in the Kyiv Children's Hospital. We share cases. We have a nice collaboration. So thank you so much. This is a brief talk on inner ear malformation made easy. And what I would like to do is to start from the anatomy and show you, and then show you some easy patterns that can be easily recognized on radiological images, but they can have an impact in your patient's management. So you can do fantastic diagnosis just recognizing some specific pattern. But to do so, I want first to promote my YouTube channel. I put a lot of simple lecture on it, and there are also some colleagues that put some lectures, so please check it out if you are interested in pediatric neuroradiology. Let's start with the anatomy. First things, the anatomy, and this is an histological spacement of, so appearances of the cochlea, and you have three important structures. This part in the middle that you can see in the high resolution 3D highly T2-weighted sequence of the inner ear here, and you can see in this drawing, is the modulus. From the modulus, what do you have is basically this bony structure going radially from the modulus to the periphery. And we have this bony structure dividing each turn in scala vestibuli and scala tympani. And this other structure here dividing the different turns. So in yellow, this structure is called lamina spiralis ossea and divided the scala vestibuli, which is up, from the scala tympani, which is down. And this interscalar septum divides each turn. Why this is so important? Because modification of this normal structure will give you some malformation that you can recognize, and you can use this pattern recognition for amazing diagnosis. And another important thing is that you need to see the nerves. So how you see the nerves? You basically create this parasagittal reformat, and you should have these four nerves, actually two very well separated, that are the eyes of this face, and then the mouth, that are two nerves linked together. So in order to remember what nerve is what, remember that 7 up and cock down. So the 7 nerves are up, so superiorly, and then you have the cochlear nerve. These two that are the mouth of this bit sad face, sometimes it's a smiley face, are the vestibular nerve, superior and inferior. This is from Radiopedia. You have the 7th nerve, the 8th nerve, and the 2 vestibular nerve. All together, the vestibular and the cochlear nerves are forming the cochleovestibular nerve, which is the 8th cranial nerve. The 7th is the facial cranial nerve. So now you have a minimal background on the anatomy. We can go further to see the pathology. So let's start with this. Okay, this is a case of a 5-year-old male with bilateral sensory hearing loss. Look at the cochlea here. I zoomed it for you, and you see that the modulus is a bit smaller than before. Maybe you can see a bit of lamina spiralis here and a bit of interscalar septum. Again, lamina spiralis divides each turn in scala vestibuli and scala tympani, and the interscalar septum divides the different turns. And here, however, you can see the interscalar septum medially, but look how flat is laterally the cochlea, and not only is flat, it's also empty in the upper part. So you have what we call an incomplete partition. Incomplete partition meaning that the partitioning of the cochlea, so the internal structure of the cochlea is incomplete. When you have some smooth lateral profile, because the interscalar septum is absent here, small modulus, empty upper part of the cochlea, you call it a specific name. I will go there from in a second. So this was reported normal, but it's not normal. So how you call it? incomplete partition type 2, incomplete partition type 1, or incomplete partition type 2 plus or plus enlarged endolymphatic duct and sac. Well, in this case, there was just an incomplete partition type 2. And why is so important? Because this is bilateral and symmetric. We have this flattening of the lateral profile, empty upper part. Incomplete partition type 2 is typical of a specific syndrome that is called Pendred syndrome. And these patients will also have goiter, so thyroid problem. So if you have bilateral incomplete partition type 2 and thyroid problem, you know that this is this specific gene, SLC26. You don't need to remember that, but you see this is extremely specific for Pendred syndrome. And another thing that is very specific, this is another case, is this tubular structure here that normally is not present, but is actually an enlarged endolymphatic duct and sac, or if you are dealing with the CT, we call it enlarged vestibular aqueduct. They are the same thing. They are associated with the incomplete partition type 2. Look again, lateral profile is smooth, empty upper cochlea. In this case, there is also dilated vestibule. Look at the difference with the normal cochlea, with the chunky, nice modulus. In this case, you can see the interscalar septum, normal vestibule, nothing here. So this is what we call Mondini triad, which is incomplete partition type 2, plus dilated vestibule that can be present or not, plus enlarged vestibular aqueduct. When you see the enlarged vestibular aqueduct, incomplete partition type 2, call it Pendred. So this is the first thing you cannot miss. And this is the CT. Again, look, the upper part of the cochlea look like a little balloon, and you have dilated vestibular aqueduct. Remember, when it's CT, we call it vestibular aqueduct. When it's MRI, we call it endolymphatic duct and sac. They are the same thing. It's just we image slightly different things, okay? And again, look the difference from a normal cochlea. So when you see something like that, remember Pendred. Again, another case, smooth lateral profile, empty upper part of the cochlea. Look the difference on corona, the spiral. Here, this is a corona. This is normal. Look, here something is missing. So remember, that's very important. And just to show you how this flattening or an emptiness of the upper part of the cochlea with the flat lateral profile correspond to this abnormality on histology. This is the normal interscalar septum. This is flat, okay? So remember, this is important, and this is just a couple of papers where some people find different way to measure this flattening of the lateral cochlea, but doesn't really matter as long as you recognize this pattern, all right? So remember, this can be very, very, very difficult to pick up, but remember, these are all incomplete partition type 2. Okay, and remember, look always for the enlarged vestibular aqueduct or endolymphatic duct and sac. That can be sometimes very little, but it's very important for your diagnosis. So now you know incomplete partition type 2 with enlarged vestibular aqueduct tell you that this is a Pendred. Look at this other case. Second pattern that you cannot miss. Very large internal auditory canal. Laterally, we have a strange profile of the cochlea, but this interscalar septum that divides the turns is present. It's not absent. However, into the cochlea, there is nothing. So you have this corkscrew, they call appearance. The corkscrew you use to pull out the corks from the bottle of bottles of wine is very similar to that. And when we see something like that, we call incomplete partition type 3. So remember, large internal auditory canal, interscalar septum present, but the rest is empty. The child is a male and is deaf, progressively deaf. This is called incomplete partition type 3. Now, I don't have time to go through all the incomplete partition and all the classification, but I want to keep it practical because I only have 20 minutes. But if you are interested, in my YouTube channel, there are all the classification, there is a lecture on the anatomy and so on. But why is important? When you see this pattern, you call it incomplete partition type 2, so fix this appearance in your mind, and you have again the genetic diagnosis. So this is X-linked deafness due to this very difficult gene, POU3F4. Doesn't matter. You see this pattern, you check on internet X-linked deafness, incomplete partition type 3, you give your clinician the gene. You don't need any complex genetic analysis. This is pathognomonic. There is only this. And again, this is another example just showing you, this is the drawing, absent modulus and lamina spiralis. That again, lamina spiralis is the part of the in the cochlea that divides for each turn scala vestibular and scala tympani, but present interscala septum with a corkscrew appearance, very much enlarged internal acoustic meatus. Okay. Now, what else we should look for? In this case, remember the development of the ear is all connected with other stuff that develops, in particular the brain and the other organ system like the kidney and so on. So you need to look at the bigger picture. You need to look at associated finding. If you have an incomplete partition type 3, you tell your clinician this is X-linked deafness due to POU3F4 gene. So you are already great, but keep looking, look at the hypothalamus. These children will have dysmorphic hypothalamus, and this is due to the fact we published that first, and this is due to the fact that POU3F4 participate to development of the brain and the ear. So look at that and check also the endocrinological profile of the patient. So this again has a lot of implication. And remember, when you see abnormal hypothalamus and a malformation of the ear that is not an incomplete partition type 3, look, this is not the best scan, but this is a very short cochlea with a bit of basal turn and nothing else. Large abnormal hypothalamus, but in this case, we have something else. We have polysindactyly. Look at this. Most of you are general pediatric radiologists, so you check the hands of the patient. They look like that. Hypothalamic hamartoma, small cochlea, but not a typical IP3, should be something else. If you Google that, this will be Pallister-Hall syndrome. So again, you can do an amazing diagnosis looking at the hypothalamus and look at the cochlea. If it's IP3, it's X-linked deafness. If it's another malformation of the cochlea with this large hypothalamic hamartoma plus abnormality in the finger, Pallister-Hall syndrome. And this has been published, and there is a specific gene. So this is a third association that is super cool and very easy to do if you remember this pattern recognition. Finally, look at this case, abnormal posterior fossa. The vermis finish here. This is the hemisphere, it's a partial volume, but the vermis is small. The pons is very, very small. Look at the cochlea. The cochlea is small. There is basal turn, nothing much here. It's not normal cochlea I've shown you before. On this other case, it's just a little bud. There is little cyst. There is no cochlea at all. But look what else is missing. Remember the anatomy. There are no semicircular canal. And there is, again, problem in the brain, abnormal cochlea, but this in this case is variable, but there are no semicircular canal. This is typical of Charge syndrome. So remember, if you don't have semicircular canal with variable appearances of the cochlea, think Charge syndrome and look at the brain. Not only, look at these three cases. Cochlea can be normal here, very abnormal here and there, but all these children have a very small cyst instead of the vestibule and no semicircular canal. All three, this is Charge. Keep looking, the brain can be abnormal, but look, choanal atresia, very, very typical of Charge, and also very typical of Charge, hypoplastic bulbs and problems in the eyes, a coloboma. So Charge, look at a lot of association, the brain, the olfactory bulbs, the coloboma in the eye, choanal atresia, like I show you here. So there is no air passing there, but most important, pathognomonic findings, no semicircular canal, all right? So we keep connecting dots, and finally, one thing I wanted to show you, look at this other abnormality here. This is a cochlea with the basal turn, and then the upper part is pushed anteriorly. On top of that, the ear look like that. There is a very weird pinna, and the ossicles are malformed. This is a small cochlea you can measure if you want, but we call unwound cochlea or anterior offset cochlea because it looks like that it didn't get to turn on itself. And when you see something like that, in association with this ear, keep looking and maybe look at the kidney. The kidney may be also abnormal. So you have kidney and this unwound or anterior offset cochlea. Look at this again, pattern recognition. This is typical of brachio-otorenal syndrome. And now what we discover, and this is the original paper, look, they all look with this anterior offset of the upper part of the cochlea, very typical, and they have associated abnormalities. So you have abnormality in the semicircular canal, ossicle abnormality, abnormal here, but the pattern recognition, disappearance of the cochlea, very typical. And what we discovered is that if you have association between kidney, so this is called branchio-otorenal syndrome because auto, so abnormality in the ear, renal abnormality in the kidney, but also you can have branchial cleft anomaly. So remember to look at the neck as well of the child, or maybe screen the child for branchial cleft anomaly. But let's say that we have another child with branchial cleft anomaly, with kidney anomaly, is deaf, but the cochlea looks like that. Instead of being anterior unwound cochlea, there is this spike here. It's a thorny cochlea. Look, the upper part is a bit irregular, the rest is normal. So what's going on? And this is also a child with a lump in the neck. This is another pattern recognition in the same syndrome. So again, it's branchio-otorenal because the child has a branchial cleft anomaly, is deaf, and is kidney problem. This is the neck of the child, similar pinna, small kidney. So what's going on? Well, this is still a bore, but the little percentage of bore, they have another gene, 6-1 gene, instead of AIA1 that is very, very common. So this is not actually, this is very important for the genetics to know. So the same syndromic association, branchial cleft anomaly, plus kidney anomaly, plus deafness, if you have a cochlea looking like that with this little spike on top, but for the rest is normal, it's 6-1 gene. If you have this typical unwound or anterior offset cochlea, same syndromic context, AIA1 gene. So looking at the ear and looking at the syndromic context, you can do an amazing genetic diagnosis. So most of the brachio-otorenal syndrome have typical unwound cochlea, but you can have this thorny cochlea in 6-1 mutation. So I show you how there is this link between the genetic abnormality involving and the appearances involving the ear and the rest of the body. Remember, bilateral enlarged vestibular aqueduct and incomplete partition type 2, especially if abnormality of the thyroid are associated, think Pendred syndrome, absence of the lateral semicircular canal charge, Bohr syndrome, unwound cochlea in most of the cases, always associated with kidney problems, sometimes branchial cleft anomaly, but these are AIA1 mutation. The other mutation is called 6-1. The cochlea is almost normal. And then we have a lot of other associations, but these are just the most important that I wanted to show you. And remember, the incomplete partition type 3, which is the X-linked deafness, typical corkscrew appearance, and look at the hypothalamus that can be abnormal. So I wanted just to show you these few cases because they are very, very nice and can allow you to do diagnosis. It's just an introductory lecture to give you a hint of what we are studying, what is very, very nice for us to know as radiologists, so this syndromic association. But again, if you like the topic, please check my YouTube channel. If there are any questions, I will be connected. And thank you very much for the invite. And I hope I will be able to visit you soon in Kyiv.